You know that really annoying feeling like your nose is just permanently blocked, you can't seem to clear it, maybe food tastes a bit
Well,
dull.
yeah, it's super common. Easy to just blame it on a lingering cold or maybe allergies.
Right, but sometimes those symptoms can actually point towards something a bit more specific going on in there.
Something often connected back to chronic inflammation, which seems to be behind quite a lot of things, really.
It really does. And today we're doing a deep dive into a condition that fits right into that category, nasal polyps.
Mm-hmm.
Now, we're actually basing this on some really useful MSRA revision notes a listener kindly shared. So think of this as us helping you unpack that material. We'll pull out the really high-yield stuff, the key facts you need, and present it in a clear, hopefully memorable way.
Yeah, whether you're actually revising for the MSRA or just want to get a better handle on nasal polyps, we'll walk you through it from, what they are to how they're spotted and managed.
Okay, great. Let's jump right in then. Based on these notes, what exactly are nasal polyps?
So the notes define them pretty clearly. They're non-cancerous growths, they're soft, and crucially, they're painless, found inside the nasal passages or sinuses.
Painless is a key word there, definitely. And what do they look like?
Well, they can vary. The notes mention they can be teardrop-shaped,
Yeah.
maybe even a bit like small grapes, so visually that helps. And they grow from the lining, the nasal mucosa.
Okay.
And the notes are specific. They often pop up in the middle meatus. That's a common spot.
Right, the middle meatus, so not just anywhere. And these notes seem to link them strongly to chronic rhinosinusitis.
That's right. Yeah, they fall under that whole spectrum of chronic inflammation in the nose and sinuses.
Mm-hmm.
But here's a really, really critical point the notes make, especially for revision.
Okay.
Because they are growths, you absolutely have to distinguish them from, well, more serious things, like tumors.
Ah, right. Okay, that makes sense. So how do we tell the difference? What's the flag?
The notes really stress this. If the symptoms, or the polyp itself, are only on one side unilateral, that's your immediate red flag.
Unilateral.
Typical nasal polyps are bilateral, both sides. So unilateral means you have to investigate further, rule out other possibilities.
Got it. Unilateral, investigate more. And what about kids? The notes mention something specific for children.
Yes, another absolute key takeaway. If you find nasal polyps in a child, the notes say you must think about cystic fibrosis and test for it. It's a really important association in that age group.
Okay, CF testing in children with polyps.
Right.
So we know what they are. Why do they actually appear?
Right.
The notes point pretty firmly to chronic inflammation.
Yeah, that's the fundamental cause, chronic long-term inflammation. But, for revision purposes, it's maybe less about just saying inflammation and more about knowing the conditions associated with it, the ones linked to polyps.
Right, the triggers or associations, what are they?
Notes list the big ones.
Yeah.
Things like allergic rhinitis, chronic rhinosinusitis itself, obviously asthma, cystic fibrosis, and also aspirin sensitivity.
Aspirin sensitivity, okay. The notes also mention Staphylococcus aureus superantigens playing a part.
Yes, they do, contributing to that whole inflammatory environment. And histologically, looking at them under a microscope, the notes say they're often packed with eosinophils.
Immune cells, right, involved in allergy and inflammation.
Exactly. They tend to have a poor blood supply, apparently, and sometimes they can change a bit, become more fleshy, reddish, due to something called squamous metaplasia. The notes even mention different types. Eosinophil-rich, which is common in the UK, infective types, or others.
And those associated conditions you mentioned, asthma, aspirin sensitivity, CF, cardiogenius, allergic fungal sinusitis, Churg-Strauss. Understanding those links is pretty crucial, isn't it, for the bigger clinical picture?
Absolutely vital. Recognizing these helps you piece things together. Why this patient might have polyps. Notice the slight nuance in the notes.
Oh.
They're careful to say polyps aren't directly associated with allergies per se, but with allergic conditions. It's the chronic inflammatory state driven by things like asthma or allergic rhinitis that seems key.
Ah, okay, that's a subtle but important distinction. So it's the underlying condition creating the environment.
Precisely.
This next section in the notes seems to cover similar ground but frames them as risk factors. So allergic conditions like hay fever, chronic sinusitis, asthma, CF, aspirin sensitivity, family history, basically reinforcing the same points.
Yeah, it's essentially highlighting what makes someone more likely to develop them. And yes, the notes list those key associations, again, really trying to hammer them home. Asthma, especially late-onset asthma.
Right.
Aspirin sensitivity, infective sinusitis, CF, cardiogenius syndrome, Churg-Strauss.
And that brings us neatly to a classic association. Every medical student learns this one. Samter's Triad, the notes call it out specifically.
Yes. Samter's Triad, definitely a must remember for exams. It's that specific combination.
Yeah.
Nasal polyposis, asthma, and aspirin sensitivity.
Polyps, asthma, aspirin.
Exactly. Think PAA, polyps,
Yeah.
asthma, aspirin sensitivity. See one, think about the other two. It's a really high-yield triad.
PAA. Got it. Good mnemonic. Okay, so chronic inflammation leads to these things, often linked to conditions like asthma or aspirin issues. But how does the inflammation actually make the polyp grow? The pathophysiology section in the notes is pretty concise.
Yeah, it doesn't go into massive detail. The core idea noted is just that the long-term inflammation of the nasal and sinus lining causes swelling, persistent swelling of that mucous membrane tissue.
And that swelling just bulges out eventually.
Essentially, yeah. Over time, that swelling leads to the formation of these polyp-like structures. The notes do say the exact mechanisms are still being researched, but the basic pathway is chronic inflammation, swelling, polyps. That's the takeaway.
Okay, straightforward enough. So someone presents with that blocked nose, maybe they can't smell properly. How do we differentiate polyps from everything else it could be? What are the key differentials listed in the notes?
Right, really important section. And we touched on the biggest clue already, laterality. The notes are very clear. Bilateral polyps, both sides, that's the typical picture.
But if it's unilateral?
If it's unilateral symptoms, or you only see a polyp on one side, you must broaden your differential. The notes specifically mention thinking about a tumor, or in kids, something called an encephalocele.
Okay. And what if it's a young child, unilateral symptoms, maybe some bloody discharge?
In that specific scenario, the notes suggest considering a foreign body stuck up the nose. Always think of that in kids with unilateral nasal issues.
Good point.
Other things on the list include chronic rhinosinusitis without polyps, just the inflammation, standard acute sinusitis, allergic fungal rhinosinusitis, and then various benign and malignant tumors, like nasopharyngeal carcinoma.
And it circles back again.
Yes, the notes reinforce it again. Always consider cystic fibrosis in a child with nasal polyps. It's repeated for emphasis.
Okay, definitely noted. Let's shift to who gets these. What do the notes say about epidemiology, especially in the UK?
So the notes give some figures. Overall prevalence in the UK population is maybe around 4 or 5%. But interestingly, for adults specifically, it's estimated lower, about 1%.
So not that common in adults overall.
Seems not. But they are much more common in adults than children. They tend to appear and peak between the ages of 40 and 60.
And any difference between men and women?
Yes, the notes state they're about 2 to 4 times more common in men. And they're rare in children and also in the elderly.
Which again underlines why finding them in those groups is significant, right? Needs that extra thought.
Exactly. It prompts that wider workup we talked about.
So someone develops them. What symptoms are they likely to complain about? We've mentioned the blocked nose and loss of smell.
Yeah, those are the big ones. The notes list the classics: nasal congestion or obstruction, feeling blocked up, a runny nose, or maybe that feeling of drip down the back of the throat, post-nasal drip.
Yeah.
Definitely the decreased or total loss of smell, which is anosmia or hyposmia. Some people get facial pressure, pain, headaches, snoring, disrupted sleep. Oh, and rhinorrhea, just a runny nose, and sneezing too.
And because smell and taste are linked?
Right. The notes point out that reduced taste often comes along with a reduced sense of smell. Makes sense.
Now, the notes flagged a couple of symptoms as being like red flags that mean you need to look harder.
Yes, absolutely. 2 key ones highlighted as unusual for straightforward polyps. Unilateral symptoms, anything affecting just one side, and any bleeding. Those warrant further investigation promptly.
Okay. Bleeding and unilateral symptoms, investigate further. How do we actually examine someone? How do we see them?
The notes describe using a nasal speculum, aiming it correctly towards the front edge of the middle turbinate. And they give some useful pointers to tell a polyp apart from normal nasal structures, like the inferior turbinate.
What are those pointers?
Polyps, according to the notes, shouldn't be sensitive to touch. They don't hurt. They typically have a kind of yellowish-gray color, and they should look separate from the side wall of the nose, not attached like a turbinate is.
Okay.
You might see just one, or maybe clusters of them, like those little grapes. The notes even mention that using a decongestant spray and maybe some local anesthetic can sometimes help get a better view during the exam.
And checking airflow.
Yeah, a little tip. Seeing if the speculum mists up can give you a rough idea if air is actually moving through that side.
Okay, so history and exam make us suspect polyps. What tests nail the diagnosis and show the extent?
Nasal endoscopy is highlighted as key. It lets you get a direct look, see the polyps, assess their characteristics.
Right. Camera up the nose.
Pretty much.
Uh-huh.
And then imaging, specifically CT scans, are used pretty often. They help see how far the polyps extend into the sinuses, or they can help rule out other things if the picture isn't clear.
And what about plain x-rays? Do the notes mention those?
Yes, and they specifically say plain x-rays are not very useful for looking at nasal polyps and aren't recommended. So it's endoscopy and CT if you need more detail.
When would you definitely order a CT, according to the notes?
Generally, it's reserved for people who aren't getting better with medical treatment, or if the symptoms are atypical, or the disease seems particularly severe. It's not usually the very first step for a typical presentation.
And what about looking for the underlying cause, the driver?
The notes suggest investigating for underlying chronic rhinosinusitis, naturally. And if the polyps are severe, or they keep coming back despite treatment, then it's appropriate to investigate for those associated conditions: aspirin sensitivity, allergic fungal rhinosinusitis, maybe Churg-Strauss syndrome.
Makes sense. Okay, so we've found them, we've assessed them. How do we treat them? The notes cover medical and surgical options.
Right. First off, the notes recommend that anyone with suspected polyps should ideally be seen by ENT for confirmation and a proper look. But the first line of management is usually medical.
And the absolute cornerstone of medical treatment mentioned?
Topical corticosteroids, nasal steroids. The notes really push these as the preferred first step. They say they can shrink polyps in a good majority of patients, maybe around 80%.
Okay.
And they offer a practical tip. Often, nasal drops might be better than sprays because they can potentially reach higher up into the nasal cavity, where polyps often are.
Drops over sprays. Interesting. What else medically?
Other things listed are antihistamines, but mainly if there's associated allergic rhinitis. Saline nasal washes or douches can be helpful, often used alongside other treatments. And leukotriene receptor antagonist drugs like montelukast might help some people, especially if they also have asthma.
What about oral steroids, steroid tablets?
Short courses are mentioned. The notes suggest they can offer long-term benefits if used after surgery, and giving a course before surgery might help shrink the polyps and reduce bleeding during the operation.
Ah, okay.
There's also a quick mention of safety concerns around injecting steroids directly into the polyps, suggesting that's generally not done.
Right. And if all that medical stuff doesn't work or isn't enough?
Then surgery is the next step. The standard procedure described is functional endoscopic sinus surgery, FESS.
FES, yeah.
Yeah. The notes describe it as generally safe and effective. It's typically reserved for people who don't get good enough results from medical therapy. Although they do add a thought that maybe doing surgery earlier could potentially reduce the long-term exposure to steroid side effects from medical treatment.
A balance to consider. And the notes seem to really emphasize those referral triggers again under management.
Yes, they hammer them home again.
Yeah.
Definitely refer any unilateral polyps. Definitely refer any child with polyps. And the reminder, test children with polyps for cystic fibrosis.
Got it.
And managing expectations is part of it too. The notes mention patient education about the fact that polyps can, and often do, come back.
Oh, and one final point on treatment. The notes clearly state antibiotics are generally not effective for the polyps themselves. They treat bacterial infection, not the inflammatory polyp growth.
Right. Good clarification. So what about the long term? What's the prognosis like for someone with nasal polyps?
Well, the notes say it varies quite a bit. Depends on the underlying cause, how severe it is, how well treatment works for that individual. Symptoms can certainly be managed, and the polyps can often be shrunk down, but the notes are very emphatic about this. Recurrence is common. Even after successful surgery, polyps often grow back over time. This is probably the single most important point regarding prognosis. Yeah, managing patient expectations around recurrence seems key.
Absolutely.
Are there any serious complications we need to be aware of?
Thankfully, the notes suggest severe complications are rare. But potential issues listed include acute bacterial sinusitis, developing as a secondary problem. And very, very rarely, that infection could potentially spread, maybe causing intracranial issues.
Okay, rare but serious.
Other things are more about quality of life, sleep disruption because you can't breathe properly through your nose, and potentially worsening of asthma symptoms if the patient also has asthma.
And what if the polyps get really, really big, like massive?
The notes do mention that in very rare cases, enormous polyps can actually cause physical changes to the face due to the pressure they exert. Things like proptosis, where the eyeball bulges forward, hypertelorism, where the distance between the eyes increases, and diplopia, double vision.
Yeah.
Again, serious but thankfully uncommon.
Okay, so let's try and wrap this up. If we were summarizing the absolute high-yield points from this deep dive, based on these notes, what would they be?
Okay, number one, think chronic inflammation as the driver. Number 2, remember those key associations, especially Samter's Triad PAA, polyps, asthma, aspirin sensitivity. They often cluster together.
And critically, don't miss the red flags, right? Unilateral symptoms or any bleeding means you need to think beyond simple polyps and investigate further.
Exactly. Always rule out more serious pathology in those cases. And remember cystic fibrosis testing for any child presenting with polyps.
Treatment-wise?
Medical first, with topical steroids being the mainstay, drops often preferred over sprays. Surgery, FESS, is for those who don't respond well to medical treatment.
And the big one for prognosis.
Recurrence is common, even after surgery. That's crucial for long-term management and patient understanding.
Perfect. So whether you are actually revising for the MSRA using notes like these, or you just wanted to get a clearer picture of nasal polyps, hopefully this deep dive has helped crystallize those key points for you.
And if you are prepping for the MSRA, don't forget there are resources out there that might help, like passthemsra.com and freemsra.com, worth checking out.